Dear students, today we are dealing with studying pathology lectures of restrictive lung diseases part 1, including idiopathic pulmonary fibrosis. This is Dr. Shaima El-Gohari, lecturer of pathology. How can we classify diffuse pulmonary diseases? As we studied previously, lung diseases divided into obstructive pulmonary diseases, which are increase in the resistance of airflow due to partial or complete obstruction of the airway, and restrictive lung disease, which is the new entity we'll take today, about reduced expansile capacity of the lung parenchyma with decrease in the total lung capacity. Again, diffuse pulmonary diseases include obstructive and restrictive lung diseases. Obstructive lung diseases we studied before, characterized by increased resistance to the airflow due to partial or complete obstruction. After excluding tumor or inhalation of foreign body, they are chronic bronchitis. Both the chronic bronchitis and emphysema are called COPD. Okay. In emphysema, as we learned previously, if there is loss of the elastic recoil of the lung. Bronchial asthma, bronchiectasis, bronchiolitis, and cystitis fibrosis are all under the umbrella of obstructive lung diseases. What about restrictive lung diseases? They are characterized by reduced expansion of the lung parenchyma with decreased total lung capacity. Occur in two conditions, either acute or chronic interstitial lung diseases as acute respiratory distress syndrome. Okay, and what we are concerned today are chronic diseases which are called sarcoidosis, idiopathic pulmonary fibrosis, and pneumoconiosis. Extrapulmonary causes like pleural diseases, obesity, poliomyelitis, and kyphoscoliosis, leading to decreased expansile capacity of the chest wall and leading to reduce the capacity of the lung parenchyma to expand to take air. Here we can study the filtration perfusion of the lung. That space inside the alveolar space lined by type 1 pneumocytes. These cells are called type 2 pneumocytes concerned in the secretion of surfactant, usually not the main lining of the alveoli, just one cell or few cells. Okay, mostly the lining is type 1 pneumocytes. Okay, here is the basement membrane of the alveoli and the basement membrane of the nearby capillary. That capillary is lined by endothelial cells, and the air enters the lung into the alveolar space, and oxygen perfused under perfusion from the alveolar space into the blood inside the capillary lumen. Okay, rest of the lung tissue, interstitial tissue of the lung, containing few fibroblasts, collagen and elastic fibers, some mast cells, very few, and mononuclear cells like macrophages. Okay. What are the chronic interstitial lung diseases? What are chronic interstitial lung diseases? Their cause is usually unknown to most of them. They are mostly overlapping as there is a similarity in the symptoms, signs, radiological finding as nodules, irregular lines, and ground glass shadows, all under this group. Grossly lung scarring, end-stage honeycombing of the lung, plus or minus, may be present in some cases and other not. It's not specific for that type of lesion. Microscopically, usually the lesion affecting both lung bilaterally in patchy manner, chronic interstitial inflammatory infiltrate with a fibrosis and plus or minus intraalveolar component like intraalveolar fibrosis and nodularity. End of this lesion leading to respiratory failure due to fibrosis of the lung and decrease the capacity of the lung to distend to take air during inspiration. Okay, and this fibrosis lead to pulmonary hypertension, what's called cor pulmonale, and right-sided heart failure. Chronic interstitial lung diseases, the hallmark feature pathophysiology of that lesion is two parts: reduced lung compliance and hypoxia. Reduced lung compliance leading to more pressure, more effort by the person to expand his lungs because they are very stiff, okay, which require increased effort of breathing. So the patient is dyspneic. Okay, dyspnea mean effort to get inspiration. Okay, hypoxia, the patient due to damage of the alveolar epithelium and endothelial cells, that site of perfusion from air into the blood, this lesion will lead to produce defect in the ventilation and perfusion ratio. Okay, X-ray investigation revealed small nodules, irregular lines, or ground glass shadow, or honeycombing, like we said before, in some cases. The complication of lung disease, as we said, pulmonary hypertension and right-sided heart failure, which is called cor pulmonale. Chronic interstitial lung diseases, including idiopathic pulmonary fibrosis, which is called usual interstitial pneumonia or cryptogenic fibrosing alveolitis. Cryptogenic and idiopathic is due to unknown cause. These names equal unknown cause. Non-specific interstitial pneumonia, cryptogenic organizing pneumonia. In this case, there is organization, which means intra-alveolar polypoidal plugs for obstruction of the alveolar space by a loose connective tissue within the alveoli and their alveolar ducts. Pulmonary involvement in collagen vascular disease. What's meant by collagen vascular disease? Autoimmune disease like systemic lupus, rheumatoid arthritis is part of the chronic interstitial lung diseases. Okay, and it is part of systemic lesion. It's a systemic disease like systemic lupus and rheumatoid arthritis, part of the spectrum of the lesion, involvement of the lung by what is called interstitial lung disease or restrictive lung disease. Okay, sarcoidosis leading to lung fibrosis and may lead to interstitial lung disease, and pneumoconiosis. We will take this in part 2 of that lecture in more details. Our first case is a 65-year-old male complaining of non-productive cough, dyspnea on exertion meaning effort. أما بيعمل exercise أو مجهود بيحصل له dyspnea. 4 months he was afebrile يعني إيه not feverish, okay, not infection. On examination, dry inspiratory crackles were heard basally and bilateral. خلوا بالكم basal and bilateral inspiratory, and during inspiration crackles يعني صوت مع inspiration, voice with inspiration due to alveolar effort to open the alveolar spaces which are rigid. Okay, X-ray showed bilateral nodularity and ground glass appearance. It's a sign of chronic interstitial lung disease. Type, it may be part of a systemic disease like systemic lupus or rheumatoid arthritis. So the physician checked the collagen diseases, were investigated, and the results were negative. Okay, clinical history exclude occupational causes of interstitial lung fibrosis like what's called pneumoconiosis, excluded also. Okay, so our patient is 65-year, complaining of non-productive cough, dyspnea on exertion for months. He also was afebrile. On examination, there was a dry inspiratory crackles, no secretions heard. And also there is bilateral and basal affection of the lung. X-ray revealed bilateral nodularity and the ground glass appearance. No collagen diseases, no occupational causes. Okay. X-ray picture of the patient reveal bilateral, more basal here. Normally, lung is that plaque due to air filling the lung. Okay, what is white here is the bone and the hard parts of the body. Okay, here is trachea, heart, that part, and the lung field upper part is clear black in color, the lower part showing bilateral nodularity and the ground glass appearance. Type. Let's start with idiopathic pulmonary fibrosis or usual pulmonary fibrosis. Age of the patient, usually old age, like in our case, is above 60 years, more commonly in males. Clinically, gradual onset of non-productive, no secretions, progressive dyspnea. Progressive يعني increasing dyspnea. Okay, characterized by patchy bilateral progressive interstitial fibrosis. It is a progressive disease. Okay, diagnosed by clinical and radiological findings, both. Okay, we should exclude collagen vascular disease, as we said, and occupational causes like pneumoconiosis. After exclusion of that causes, it is of unknown etiology in old age, so it is idiopathic pulmonary fibrosis. Okay. Pathogenesis of idiopathic pulmonary fibrosis. What caused lung injury? It is either environmental factors like exposure to smoking, metal, wood dust, or gastric reflux. It is discovered lately. Genetic predisposition like age of the patient, it's old age disease, and telomerase defect. It's a genetic defect in telomerase enzyme. Epithelial cell type 1 pneumocytes, which are the most common cell forming the lining of the alveoli, underwent injury by that genetic or environmental factors or both, leading to their injury and activation. Their activation will cause inflammatory infiltrate like lymphocytes. Also, their injury will produce transforming growth factor beta, leading to inhibition of a material called clavulin in the fibroblast. Normally, clavulin دي بتعمل inhibition of the fibrosis. So, fibrosis will be formed. Okay. Both inflammatory cells and clavulin both will cause what is called profibrogenic factor. It's lead to fibrosis. Also, transforming growth factor beta will cause abnormal epithelial repair. It's epithelial injury followed by transforming growth factor beta production that will cause to repair of the epithelial cells, but that repair is abnormal. Okay, so that epithelial cells or endothelial cells, instead to be repaired to form epithelial cell, it will be transformed into fibroblast and myofibroblast. So the net result, it will be more fibrosis, more collagen deposition, more extracellular matrix formation, and net result is pulmonary interstitial fibrosis. Okay, so patient will enter into repeated cycles until it will be a full-blown picture of idiopathic pulmonary fibrosis. طيب يبقى تاني pathogenesis of idiopathic pulmonary fibrosis either environmental or genetic or both together. Environmental factors like smoking, wood dust, okay, زي النجار, metal dust, gastric reflux, it is recently described. Genetic factors as inherited genetic defect in telomerase enzyme, loss of its function in familial IBF. Repeated cycles of epithelial cell activation and injury will lead to some agents. Epithelial cell will produce transforming growth factor beta that will inhibit clavulin 1 in the fibroblast, and the clavulin normally inhibit fibrosis. So, no inhibition of pulmonary fibrosis, and it will be pro-fibrogenic effect. Also, abnormal repair of the epithelial cells and transformation of them into fibroblast and myofibroblast, this will add more fibrosis to the lung. Pathologic features and the growth of the IPF or inflammatory pulmonary fibrosis. As we see here in the picture, there is that these two lines, streaks of bands of interstitial fibrosis. Also, there are these cavities, openings like a honeycomb appearance. Okay, that cut surface show a honeycomb appearance, mostly al periphery, called temporal. Okay, under the pleura, that irregularities called a copelestone appearance, honeycomb appearance, and that under the pleura is called copelestone appearance. أخدنا copelestone قبل كده. Previously we take copelestone in GIT. Okay, Crohn's disease. Yes. Okay, so pathological feature grossly, the outer surface showed a copelestone appearance due to fibrosis and cavities. Fibrosis and the cavities, that honeycomb في cut section. Okay, retraction of the scars along the interstitial septa. Okay, that retraction will be dipping areas and elevated areas. Okay, pathologic features of idiopathic pulmonary fibrosis or usual interstitial pneumonia pattern. It's called patchy interstitial fibrosis. What's meant by patchy? Area of fibrosis and normal lung. Other area of fibrosis and normal lung. Okay, variation in intensity and age of the fibrosis, not age of the patient. Okay, intensity from mild to severe, and age of the patient from well-formed fibrosis and collagen deposition into starting fibrosis. Okay, here example of the well-formed, that collagen nodules, more collagen area, it's old lesion, and more cellular area containing fibroblast and myofibroblastic foci, which are called cellular fibroblastic foci, and it is the earliest lesion. Okay, both lesions are present in the same patient at the same time. Okay, the lesion is more temporal and heterogeneity. Okay, again, cellular area and collagenous areas. Okay, mature collagenous and fibrotic areas, و fibroblastic foci, meaning presence of fibroblasts. Okay, some alveoli will undergo collapse and other will form a cystically dilatation lined by hyperplastic, usually lined by type 1 pneumocytes, but it is abnormal lining. It will be type 2 pneumocytes. Okay, or bronchial epithelium. Okay, giving the honeycomb and fibrosis in between. Pathologic features of IPF microscopic will be, again, variability in the intensity of inflammation. What type of inflammatory cells? Plasma cells, lymphocytes, some macrophages, eosinophils, mast cells, and thickening of the muscular arterioles, changes in the pulmonary arterioles due to pulmonary hypertension leading to intimal fibrosis, smooth muscle thickening due to hyperplasia and hypertrophy. Okay. Any volunteer? What that area? It is a fibroblastic area, recent area, cellular area, and it is all the area collagenized areas. Okay, fibroblastic foci and collagenous areas. Yes. So back to our case. A 65-year-old male complaining of non-productive cough, dyspnea on exertion for months. He was afebrile. On examination, dry inspiratory crackles due to sudden opening of the small rigid airways, okay, by the hard or intense effort to inspirate. Okay, these crackles are heard basally and bilaterally. Okay, on chest X-ray, bilateral nodularity and ground glass appearance detected. We excluded collagen vascular disease and history of occupational diseases. What are the clinical features of IPF? Gradual increased dyspnea on exertion, dry cough as in our case, crackles heard during inspiration, okay, sudden opening of the alveolar walls, hypoxia, it is a common feature in the interstitial pulmonary disease, cyanosis, clapping chronicity of the case, okay, deterioration gradually despite the treatment, due to fibrosis, more obstruction of the lung. Okay. This is a CT picture. This is heart, spine, aorta, and other structures here. Right or left lung and right lung. Both lungs showed that cavities, peripheral or temporal here, here, and here. It is called, yes, honeycomb subpleural imposition. Okay. Chronic interstitial lung disease، احنا كده أخدنا idiopathic pulmonary fibrosis، ودلوقتي هناخد ال non-specific interstitial pneumonia. اوكي، كلمة pneumonia هنا pneumonia meaning consolidation. Consolidation يعني instead of being spongy, normal lung is a spongy tissue, instead of being spongy it will be solid like liver. What's called consolidation. Okay, in that entity it's not infection. Okay, meaning هنا احنا حاطين pneumonia عشان نقول ان هي بقت solid. Okay, we used the term pneumonia here to identify a solid nature of the lung instead of being spongy normally. Okay, due to fibrosis. Non-specific interstitial pneumonia, the patient of this group showing diffuse interstitial lung disease, their lung biopsies lack the diagnostic features. أنا مش عارف أقول إيه common cause of that fibrosis. عندي there is lung fibrosis and lacking the diagnostic features. No granuloma, so it is not sarcoidosis. No fibrosis old و recent عشان أقول interstitial pulmonary fibrosis. Okay. No diagnostic feature of any of the well-characterized interstitial diseases. Okay. Why بقى? They have better prognosis than the usual idiopathic pulmonary. Non-specific interstitial pneumonia is a chronic bilateral interstitial lung disease of unknown etiology. Morphologically, it is either cellular pattern or fibrosing pattern. Cellular pattern means inflammatory infiltrate, which is mild to moderate interstitial inflammation, mostly by lymphocytes with very few plasma cells. Okay, or fibrosing pattern, which is diffuse or patchy interstitial fibrosis. There is no temporal heterogeneity or honeycombing like in IPF. Non-specific interstitial pneumonia, is it cellular or fibrosing pattern? Yes, it is cellular pattern. Okay, because of this dense inflammation, mostly formed of lymphocytes with very few plasma cells. Okay, no fibrosing patches detected here. Okay, this pattern is called fibrosing pattern. The alveolar septa markedly thickened, markedly rigid by presence of the fibrosing reaction. Okay, to summarize, pathologic feature of idiopathic pulmonary fibrosis, grossly there is bands of fibrosis, honeycomb on the cut section and outer surface revealed, yes, cobblestone pattern. Microscopically there is a temporal heterogeneity, fibroblastic and collagenous areas, recent and old areas of fibrosis. Non-specific interstitial pneumonia, cellular pattern and fibroblastic pattern. Cellular pattern, there is inflammatory infiltrate, mostly lymphocytes with very few plasma cells, and fibroblastic type, there is diffuse or patchy fibrosis. No temporal heterogeneity like in IPF. Okay, sarcoidosis. Yes, it is a multisystem disease forming non-caseating granulomatous inflammation, and later on it will be fibrosing. Cryptogenic organizing pneumonia, there is intraalveolar, Yes, polypoidal plugs of loose connective tissue within the alveoli, obstructing the alveolar spaces and alveolar ducts. Okay. Who will answer that activity? First one, characterized by single pattern of interstitial lung disease, either cellular or fibrotic pattern, not heterogeneity. Yes, it will be non-specific interstitial pneumonia. Second one, characterized by interstitial non-caseating granuloma and later fibrosis. Which one forming granuloma? It is sarcoidosis, yes. Okay, there is one disease showing multi-system affection with affection of lymph node, lungs, spleen, liver, eye, parotid, and the end result will lead to also fibrosis. Yes, it is also sarcoidosis. It's a multi-system disease. 4. It is characterized by patchy interstitial fibrosis with early fibroblastic foci and old lesions. Heterogeneity. Which one? Yes, IPF, idiopathic pulmonary fibrosis. Number 5, it is characterized by presence of plugs, which are polypoidal, formed of loose organizing connective tissue inside alveoli and alveolar ducts. Yes, it is cryptogenic organizing pneumonia. Okay. Chronic interstitial lung diseases including idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, and pneumoconiosis. We will study that entity in another part of that lecture. Thank you.